Hello, and welcome to Do or Not to Do, Ethics in Speech Pathology. My name is Tracy Grammer. I do have some financial disclosures. So I am a full-time speech-language pathologist at the Stevenson Cancer Center of OU Medicine in Oklahoma City, Oklahoma. So they do give me a paycheck to talk about the things that I love. I'm an adjunct professor for the Department of Communication Sciences and Disorders at the University of Oklahoma Health Sciences Center. I'm also a paid invited lecturer for cognition, dysphagia, ethics, voice and swallowing issues, tracheostomy, and mechanical ventilation. I'm also a per diem consultant for Atos Medical. My ASHA registration is paid each year by Janelle Publications for my role as a convention booth specialist. Non-financial disclosures, I am a faculty member for the Department of Otolaryngology at the University of Oklahoma College of Medicine. I'm a member of the ASHA Board of Ethics, former member of the ASHA Advisory Council, former member of the ASHA Legislative Council. I'm a member of the Oklahoma Board of Examiners for Speech-Language Pathology and Audiology. I'm president of the Oklahoma Brain Injury Association from 2002 to 2007. I'm a former president of the Oklahoma Speech-Language Hearing Association. I am an ASHA Fellow, and I am a board member of the National Council of State Boards for Speech-Language Pathology and Audiology. There's what you're going to learn. So ethics, what are ethics? Ethics is defined as the discipline dealing with what is good and what is bad, and with moral duty and obligation. It's a set of moral principles, or a theory, or a system of moral values. They're the principles of conduct that govern an individual or a group of professional ethics. It's a guiding philosophy, a conscience of moral importance. So those are the definitions of ethics, but how does it fit into what we do? Well, we look at ethics as speech-language pathologists and audiologists in three different ways. One is to do no harm, and that's a prohibitive ethic. It includes prohibitions against fundamentally unprofessional actions. Example, to avoid bribery, inappropriate relationships with those patients that we see or their family members, murder, theft, fraud, conflicts of interest. Those are all prohibited by prohibitive ethics. We can see those in the ASHA codes of ethics by looking at Principle 4, Rule E. Individuals shall not engage in dishonesty, fraud, deceit, or misrepresentation. Also in Principle of Ethics, Rule G. Individuals shall not engage in harassment, power abuse, or sexual harassment. Also Principle of Ethics 4, Rule I. Individuals shall not knowingly allow anyone under their supervision to engage in any practice that violates the Code of Ethics. Those are prohibitive ethics. Aspirational ethics are those ethics that say what if, that look forward. So using one's professional knowledge to promote human well-being. They consist of guidelines and motivating considerations for using professional expertise to promote human well-being. They allow the profession more discretion in determining what it involves and how and when it is implemented. For example, serving underserved populations, therapeutic and medical devices, so that we know we can rely on our own clinical judgment when to use this device and when not to use this device is one example. We can find aspirational ethics in the ASHA Code of Ethics Principle 4, Rule A. Individuals shall work collaboratively when appropriate with members of one's own profession and or members of other professions to ensure the delivery of the highest quality care. Also in Principle 2, Rule G, individuals shall make use of technology and instrumentation consistent with accepted professional guidelines in the areas of practice, such as technology. When it's not available, an appropriate referral may be made to someone who has that technology. That's an aspirational ethic. Preventative ethics are proactive activities that are performed on behalf of the client or patient to prevent or reduce harmful behaviors. It's mandatory for all members of the profession. Preventative ethics are those ethics that we don't really think about very often. We don't think about, if this happens, am I culpable? Am I responsible for this? It's a basic case question of what if. What if I see this patient and I know that his blood pressure is low at the end of my session and he's not feeling well, but I do nothing about it. And he walks to his car and he falls in the parking garage and hits his head. Does preventative ethics say that I'm responsible for what happened to him because I didn't say, what if this happens and this happens and this happens? I like to use the example of Sesame Street. Some of you may be old enough to remember Sesame Street. If you remember, there was a little kid with a balloon. And she had a pen in one hand and the balloon in the other, and she said, what would happen if I popped this balloon? Preventative ethics says, if I pop this balloon, it'll make a loud noise, and that loud noise will scare the cat. And the cat will jump up onto the counter, hit the vase will fall off and crash, and that noise will wake my sister. My mom will get mad at me and I'll get in trouble. What if I pop this balloon? What will happen? Will I be responsible? Preventative ethics are those things that we don't think about as often as we should. Because when we see these patients and they're not feeling well, their blood pressure's high, their O2 saturations are low, or it's a child who looks like they've been in some abusive situation, or a patient who looks like they've been in an abusive situation or a harmful situation, and we don't take that next step and something bad happens, are we responsible? Answering this question leads the person to look ahead to recognize possible outcomes. If I don't take action, what could happen? The decisions that we make about prevention should be made on logic rather than emotions. So you can't let your head rule your decision about preventative ethics. Well, if this patient looks like they've been in a harmful relationship, they look like they're getting hurt at home, and I do something about it, I'm going to have to get involved. I'm going to have to write all this paperwork up. I could get called into court, and I don't want to do that. That's very stressful. That's basing that decision of prevention on emotions rather than logic, and we can't let that rule our system of preventative ethics. Prevention is the highest form of healing. How many of you ever heard a stitch in time saves 9? All of us have. That's what our mothers and our grandmothers taught us. This is what that talks about, that if we take an extra minute to do something about a situation that could be problematic, are we going to save that person's life? Are we going to take them out of some harmful way? This is like the situation where if someone's in a bar and they've had too much to drink and the bartender lets them drive home, is the bartender responsible for that person or the people injured if he gets into a wreck? And the answer is absolutely yes. Many years ago, bartenders started being held accountable for this in courts of law. And they can get in trouble if they let someone who's obviously inebriated drive home and something happens. Preventative ethics aren't just for our grandmothers and for bartenders. They're for all of us as professionals. So some people say, well, that's not my circus, it's not my monkey. Well, when is it okay to get involved in someone else's life? When is it okay to say, you look like you're in a harmful relationship, you look like you're being hurt, I'm going to interfere? Some people might say, it's not my circus, not my monkey. What's acceptable, what's unacceptable in that situation? When are you crossing those lines? And these are all open to interpretation, but the law tells us that if something happens and we could have prevented it with one of our patients, we are culpable, and the law being our code of ethics. So when is it okay to interfere with children but not adults? People seem to be a lot more available or a lot more free to interfere when a child looks like they're in an abusive situation rather than an adult. So if a patient comes in and they smell of urine and they're unkempt and they have bruises and they cry hysterically all the time and don't want to talk about their family life. Now let's put that onto a child who comes in and they have bruises and they cry and won't talk about their family life and they're unkempt and smell of urine. Would you be more willing to say something about the child or the adult? When is it okay to say something? When is it not okay? So the Code of Ethics for ASHA in Principle 4, Rule N tells us that individuals shall report members of other professions who they know have violated the standards of care to the appropriate professional licensing authority or board, or other professional regulatory body or professional association when such a violation compromises the welfare of persons or services or research participants. So that could be a teacher, that could be a caseworker, it could be a nurse in a nursing home, it could be another speech pathologist, a physical therapist, it could be a physician, it could be parents. The ASHA Code of Ethics in Principle 4, Rule 4 of Principle 4, Principle 4, Rule R, says that individuals shall comply with local, state, and federal laws and regulations applicable to professional practice, research ethics, and the responsible code of conduct for research. So, we have to obey our state laws. So we're licensed through OBESPA, through the Oklahoma Board of Examiners for Speech, Language, Pathology, and Audiology. We're also governed by the state of Oklahoma laws. So ASHA says that we have to follow what our state law says. We have to practice within those practice acts, as do other members of other professions. So when we talk about preventative ethics, we say, well, is this right? Is this wrong? Is this legal? Is this illegal? Is it immoral or is it moral? So what is the difference then in ethics and morals and law? So as clinicians, we cannot impose our system of morals onto our ethics system. We cannot impose our system of morals onto the legal system. So ethics and morals relate to what is right and what is wrong. It relates to that conduct of telling us right behavior versus wrong. So rules give us an external source. Example, codes of conduct in the workplace or principles in religions. Ethics govern our professional interactions with one another and with our patients. Morals refer to an individual's own principles regarding what's right and wrong. So it's what I think is right, what I think is wrong, and the goodness or badness of human character. Where morality governs the private, personal interactions, okay? So if I think that it's okay to shave my head and let's say my religion may tell me that it's not okay to get tattoos, but it is okay to shave my head. It's immoral to get tattoos. Your religion may say that it's fine to shave your head and to get tattoos. That's a personal interaction. That's my own private guideline. It's what I think is right, what I think is wrong. The law is the system of rules of a particular country, a state, or a community that regulates the actions of its members and may be enforced by the imposition of penalties on that person for not following those guidelines, okay? So the law governs the society as a whole, and it deals with the interactions between total strangers. So the morals are my own guiding principles. The law is my interaction with other people that I don't know. So it tells me that it's illegal to shoot someone. It's illegal to kill someone. It's illegal to drink and drive. That's the law. I may not see anything wrong with drinking and driving. I may not see anything wrong with going 58 miles an hour rather than 55. But the law says it's illegal. I may think it's immoral to drink alcohol, even though I'm well over the age of 21. The law says it's legal to do so. Do you see where morals and the law are different things? So ethics and morals, remember that both relate to what is right and wrong. Ethics refer to the rules provided by an external source on me, on my profession, or on my religion. Morals are internal. They're what I think is right, what I think is wrong. The law demands an absolute subjection to its rules and its commands. You have to follow the law if you're part of a society, a community, a state, or a country. There are rules that are developed by government in order to provide balance in society and protection to its citizens. So we have speed limits to keep people from getting in horrific crashes. Actually, that's not true. Do you know where speed limits came from? So they were established in the 1970s when we were in gas crisis, and they were trying to figure out when cars got the most efficient miles per gallon, and they found out that cars are the most efficient in their use of gasoline at 55 miles per hour. They also, kind of off the side, found out that if people aren't going 120 miles an hour, they aren't injured as badly in crashes and they have more control of their vehicles. So now speed limits are because we want to protect the members of society. But when they were established, it was to get more miles per gallon. So the law has an enforcing authority that's derived from state and enforced by the government to its people. So they're come up with the people, enforced by the people. It's imposed upon men by men. So there's no overarching entity or deity that imposes this. It's men imposing it on men. And it regulates our relationships with others and with society. So the law is absolute. It has nothing to do with what we internally think is right and wrong. Morality says that we should act from a sense of ethical duty, that we are supposed to behave, we're supposed to act right, because that's our duty to act right. There's no such enforcing authority from the state, and it's autonomous. It stands alone, but it governs our inner lives. So it's not against the law for someone to have an extramarital affair. In someone's code of morals, it may be against that code of morals, okay? So it's not illegal to have an affair. It may be immoral according to a person's own viewpoint of that situation. It's not enforceable by the court of law. It's accompanied by a corresponding right, okay? Morality has that accompanying right, but it's not an enforceable right. So the law has no jurisdiction over morality. There's no such organization that can govern your sense of what's right and wrong, okay? Moral rules do not admit, even in principle, by change of legislation. So if the law changes, that does not change what you think is right and wrong. What's the big hot topic right now between parties about this should be legal, this should be illegal? Marijuana, what else? What's another one? Abortion, okay? So people have their very steadfast viewpoints on abortion. If the law changes and says this is legal or this is illegal, does that change how you think about it? That's a perfect example of law versus moral, okay? It won't change your morals just because the legislation changes about it. But morality applies to every single human act. Every single thing that we do, every decision that we make is driven by our sense of morality. Okay? It applies to all people. So everyone has a sense of morality. Now your sense of morality may be different from someone else's. So I took a class one time where our assignment was to watch a show called Sons of Anarchy. Because we were talking about how every society, no matter what society it is, has their own system of morality and their own legal system and their own sense of ethics and their own sense of justice. So if you take a show like Sons of Anarchy, which is about a motorcycle club, and it's a pretty active motorcycle club with illegal activities according to the law. So in this society, if you look at their behavior, it's all guided by their sense of morals and by their sense of ethics. It's illegal if you look at the outside law that's applicable by the state and by the nation, but in their own society, they follow this sense of morality and this sense of ethics very closely. To people looking from the outside in, a lot of those acts are heinous, but in that society, it's the norm, and it's their sense of morality that guides those actions, okay? So morality depends on people, and it differs from society to society, from person to person, and from religion to religion. And it's your pleasure to follow those or not. Sometimes morals get converted into law, but that doesn't change how people think about that. So a lot of laws were driven by people's sense of morality. That's what started the law in the first place, but it doesn't change how individuals feel about that. Okay? So what about the code of ethics? Where does it stand if we think about the law versus our sense of morality? Well, the code of ethics clarifies an organization's mission or their values and their principles. It establishes those standards of conduct by which we all have to adhere. It serves as a reference for the members of that association or that profession and the recipients of those services. the American Speech-Language Hearing Association and the Oklahoma Board of Examiners for Speech-Language Pathology and Audiology have codes of ethics. The state licensure boards have initial jurisdiction over the licensees, okay? So a lot of people get confused on that, and they think that ASHA overrides the state law or the State Practice Act. They do not. Your state licensing board has overarching jurisdiction over your practice. So if the state says you cannot do this, but ASHA says you can, which one do you follow? You follow the state licensing board or the state licensing act, because they have that overarching responsibility and jurisdiction over your licensing. So on the ASHA Board of Ethics, we frequently get referrals on cases that have been sent to us from previous actions of state boards. So if a state board takes an action against your license, and then that case gets sent to the ASHA Board of Ethics, we cannot change any sanctions put forth by the state licensing board. Those stand. We have no jurisdiction. We cannot change any sanction put upon you by your state board. But ASHA can have separate sanctions. So in the case of ethical violations, you can have sanctions put on you by your state board and sanctions put on you by ASHA. We cannot reverse a decision that has been made by a state board. We cannot change a sanction. We cannot change a fee that your state board has put against your license, okay? So the ASHA Code of Ethics is intended to ensure the welfare of the consumer, the people that we treat, the clients, the patients, the students that we treat, and to protect the reputation of the profession and to protect the integrity of the profession. So if you have a wayward speech pathologist or a wayward audiologist who's out wreaking havoc in the speech pathology or audiology world, we don't want that to reflect badly on our professions and to have people say, well, you know, those speech pathologists, I hear they're a wayward group of people. So we want to protect the reputation of our professions. The ASHA Code of Ethics also provides a framework and a focused guide for the professionals to support your day-to-day decision-making related to professional conduct. So this gives a guide for you to look back on and say, oh, I can do this, I shouldn't do this. In this situation, this is what I should do. So that you're not imposing your sense of morality on your professional practice. They need to stay separate. So this Code of Ethics gives you that guideline to prevent you from putting your morality in your profession, okay? So when we look at the ASHA Code of Ethics, there are many versions of it. So there's a version of 2003, 2010, there's a 2010 revised, and there's a 2016. So I want to talk a little bit about some changes to the ASHA Code of Ethics in 2016. And I'll tell you, when a complaint comes in to the ASHA Board of Ethics, we look at a couple of things to decide which Code of Ethics are going to be applied to that accusation. It depends on when the act was committed. If the act was committed in 2002, we're going to look to an older code of ethics, because we don't want to apply a code of ethics that wasn't in place when the infraction or when the alleged offense occurred. So if something happened in 2015, we're going to look to the 2010R. If it was 2017, it'll go to 2016. So we look at the most recent code of ethics closest to the date when the alleged offense occurred, okay? So some recent changes in the Code of Ethics. In Principle 3, they just simplified the wording to clarify the meaning of some things and removed examples, just cleaned up some of the language. In Principle of Ethics 4, they edited the wording to enhance its aspirational nature. So remember we talked about aspirational ethics? We want to do good. So they just changed the wording to enhance that to reflect those codes of ethics. They also added 15 new rules of ethics to include research conduct, evidence-based and clinical independent judgment, client abandonment. You guys know what client abandonment is? So client abandonment is if you're a provider for a certain set of clients, let's say that you're a school-based speech pathologist and you work in a rural school and there's no one to see the clients, and you quit without notice, and you quit without anyone being able to see your clients. That is client abandonment. Let's say that you work in a hospital and you fit tracheoesophageal voice prosthesis and there's no one else around who can do that, and you quit without notice and leaving the hospital or the doctor's office without anyone to see those patients. That is client abandonment. When you leave a caseload and there's no one to see those patients, so they're left without services. That's client abandonment. Impaired practitioner. So what is something that's going on right now in many states where we have to wonder, how does this affect impaired practitioner? Marijuana. That's exactly right. So with the legalization of marijuana or even medical marijuana, how does this affect the code of ethics? So I like to say this is like oxycodone or hydrocodone. Those are not illegal. They're legal substances. Alcohol is a legal substance. How does your workplace deal with you if you're impaired on oxycodone, alcohol, or hydrocodone? It's going to be the same thing as medical marijuana. An impaired practitioner is an impaired practitioner. And it doesn't matter if it's from a substance such as marijuana or alcohol or narcotic pain relievers, or if it's from having maybe some psychiatric disorder or psychological disorder where you're impaired, or a medical disorder where you're impaired and no longer capable of making those independent decisions. So it will be about the same. So a lot of it will be related to the workplace and the workplace rules and that they set in place, but an impaired practitioner is an impaired practitioner, no matter what the cause. Workplace service delivery coercion. What does that mean? What does that mean to you? Your boss making you do something that you don't think you should do. So might we run into this? Billing or productivity. So we've heard a lot about productivity issues where people are forced to get a certain amount of productivity. So you especially see this in what settings? Skilled nursing facilities, long-term care facilities, hospitals even. So a lot of times the complaints that we hear are that the clinicians were forced to have people on their caseloads that they didn't think were qualified for therapy. So ASHA now has included language to deal with this type of issue. Where else might you see this? So with states licensing assistants for audiology and assistants for speech-language pathology, you might see some workplaces forcing people to be supervisors when they don't want to do it. They're forcing them to be supervisors for paraprofessionals, for these assistants, or for clinical fellows when they don't feel they're trained or they don't feel they want to do it. ASHA now has language to talk about workplace service delivery coercion, when you're forced to do something that you don't think is right or you don't think you're ready to do. ASHA also has included language about the use of technology, because as we advance through computer technology and engineering, we have more and more gadgets to use. So how does ASHA feel about people using gadgets? We want to make sure that they're trained to do it. We want to make sure that people aren't being forced to do things or not doing things with something just because they have it when they're not trained to do so. They included language about self-disclosure. So that's why when you go to a presentation and we have to talk about all of these things, we're not bragging and saying, yay for me, we have to do this. And why is that? Because if I'm being paid to do something by a company and it's influencing my lecture, might I skew my lecture to show benefit to that company that's paying me? So we have to tell you, I have this financial relationship, I have these non-financial relationships, because we want you to know that there might be a little bit of that prejudice so that you can interpret it as you will. Honesty in reporting. Honesty in reporting is me telling you I have these financial relationships, but it's also me filling out a form to get a state license and admitting that I've had felonies or admitting that I've had these actions taken against my license in another state. So if I apply for licensure, I have to be honest in reporting all of the things that might affect my practice. Intraprofessional and interprofessional collaboration. How well do you get along with members of our own profession and members of other profession with which you interact? The school principal, the school nurse, the school psychologist, physicians on the team, physical therapists, occupational therapists, anyone that we work with or that might work with the same clients or students or patients that we see, how well do we get along with those people in treating our patients? Reporting members of other professions and our profession. This is a tough one. And we're going to talk about that more in just a bit. And compliance with local, state, and federal laws and regulations. So this one deals with the fact that if you have 12 DUIs, you're not in compliance with local, state, and federal laws. So how does that affect your ability to practice your profession? If you get busted for shoplifting 7 times in 1 year, how does this affect your ability to practice as a speech pathologist or an audiologist? If you have a narcotic problem and you get arrested for narcotic possession and intent to distribute, how does that affect your professional practice? So if we think about all of those new changes, certainly we have what we consider an ethical dilemma. What is an ethical dilemma? How do we know if this is a situation of my morals versus your morals, illegal versus legal, or is this a question of ethics or not? An ethical dilemma is when there's no right or wrong choice. There's no right or wrong answer. Illegal versus legal, there's a yes and a no. It's illegal to drive 58 miles an hour in a 55 mile an hour speed zone. It's not illegal to drive 53. Although we might interpret it quite the opposite. In this society, we think it's illegal to drive 53 in a 55. But there's a right or wrong answer to that question. So another thing that we have to consider when we look at ethical dilemmas is, if no one was injured or harmed, is it really an ethical issue? Nobody got hurt. What does it matter? What are the final consequences? Okay? So when we look at resolving ethical dilemmas, we think, how do we do this? If there's no right or wrong answer, how do I know? And besides all that, nobody was really hurt. We have to have a stable decision-making process. So to solve these ethical dilemmas, we say, what's the problem? What are all the facts leading up to this problem? We have to define it. We have to collect the relevant facts, okay? Then we have to identify the rules, the policies, and the best practice to determine what the options are. So did they violate the law? What were those laws or policies or principles? Then I can decide what my options are. Do I go to a supervisor? Do I report them to the state board? Do I turn them into ASHA? What are my options? Then I have to think about the effect of each of those options. If I go to my boss and I say, hey, I think this is going on, what are the effects of that? If I go straight to ASHA or straight to OBESPA, what are the effects of that? If I take this pin and I pop this balloon, what's going to happen? If I throw the pin in the trash and get rid of the problem, what's going to happen? If I put the cat outside and then I pop the balloon, what's going to happen? So I have to look at all of the options, and then I have to think of the effect of each one of those, okay? And then, after I've done all of that information gathering and thinking about the options and the effects, then I need to review all of this information with my chain of command. I don't need to stand as an island and try to make this decision on my own. And I'm going to go to that chain of command and make the most appropriate decision. And then I'm going to select that option and I'm going to act on it. So things I have to consider when I'm trying to decide about an ethical dilemma. What are the implications that I'm facing? What's the impact to the patient or the client or the student? What if I do nothing? What if this continues? Or what if I do something? What is the impact to my license, my certification, if I do this or if I don't do this? So now, according to the Code of Ethics 2016, Principle 4, we have an ethical obligation to report people that violate the ASHA Code of Ethics or the OBESPA Code of Ethics. If you knowingly allow someone to do something that's unethical, you are just as culpable. What's the impact to my employment? So when we talk about those work service delivery coercion situations, some people don't want to report that because they think I might get fired. I might lose my job. If I lose my job, what will happen then? What's the impact to the reputation, to the integrity of my hospital, of my school, of myself, and of the profession? Those are all things that we have to consider and that we frequently do consider. So we think, well, we have these ethical dilemmas. So sometimes it's very obvious. We think speech pathologists would never commit billing fraud for millions of dollars. Oh, audiologists would never falsify treatment records for fictitious clients to attain reimbursement from third-party payers. Speech pathologists nor audiologists would deem a student eligible for speech-language pathology or audiology services in the public schools to exchange money and goods from parents. Speech pathologists would never engage in inappropriate relationships with minors. They would never practice speech pathology or audiology under the daily influence of alcohol or marijuana. Or would they? So these egregious violations are very easily identified and dismissed as things we would never do. Well, let me tell you, every single one of those things has been a case that we have heard on the Board of Ethics in at least the last 2 years. Murder for hire, attempting to drown your baby, inappropriate relations with a 2-year-old client, posting pictures on the internet, 12 DUIs in a 9-month period, shoplifting. Those are egregious violations that we say we would never do that. I would never do that. That's illegal, that's immoral, and it's unethical. Those are easy to identify. So there's no question, and we think, well, why would this 3-hour course change my behavior? If I'm going to hire someone to kill someone, if I'm going to get 12 DUIs in 9 months, this 3-hour course is not going to change my behavior, right? So why does OBESPA require that I have 2 hours of ethics training every 2 years? Are they trying to keep me from hiring someone to murder someone? Are they trying to keep me from getting DUIs or coming to work under the influence of marijuana? January 1, 2020, ASHA will now start requiring ethics as a continuing education course to maintain your certification. Are they trying to prevent these egregious things from happening? Absolutely not. Many ethical violations are unintentional, and they're the result of incomplete documentation, inattention to detail because we're in a hurry to get home, because there's a band playing at the Jones Assembly that we really want to see, or because our dog has been in the crate way too long and we need to get home, or that daycare will charge us $1 a minute after 6 if we don't get there. So we hurry through things and we have inattention to detail, or we have incomplete knowledge. So let me talk about some scenarios in ethics. This is called Catch Me If You Can. So a speech pathologist who works in a private practice treats children and adults, and this clinic employs 35 clinicians. Services were billed to third-party payers, including Medicare and Medicaid. An audit by the Medicaid system revealed that individual therapy for 92507 was billed for multiple clients at the same time by the same clinician. That's individual therapy, okay? So when Medicare interviewed the staff of this private practice, they found out that services were being billed by bachelor-level clinicians. Each child received the services according to the plan of care for the duration and the frequency as specified on the plan of care. They got the services they needed. Was there any harm? The child received the services they needed, so what's the big deal? The documentation, however, was performed by a single the documentation was performed and signed by the speech teachers, by these bachelor level clinicians, not the speech pathologist. So a single person did the therapy and wrote the documentation. But they used the provider number of the speech pathologist. Not all of the speech pathologists who worked for this private practice were involved in this activity, but they all knew it was happening, okay? They all knew it was going on, but they weren't all doing it. What ethical issues exist? What? Forgery. So they were using the provider numbers of the other speech paths. So what else?
Knowing unethical things going on and not stopping them.
Knowing unethical things were going on and not stopping them. What else? How about fraud, misrepresentation? Exactly. So who's culpable for these ethical violations? Who's responsible for this stuff? Was it the speech pathologist who was letting them use their identification number? Was it the speech teachers who were doing it? Was it the speech pathologist who knew it was going on but said nothing? Was it the private practice owner? All of them. Okay? So the speech pathologists who were not engaging in those activities were also in violation because they knew it was happening and they did nothing to stop it. Okay? So going back to that one, why would the private practice owner be culpable? They're ultimately responsible. Did she set it up? Did she encourage them to do this? Was this the way that they did things? So what about the new graduate who's hired by this practice and they were told by their supervisor, this is the way we do things, this is the way you will do it? Is that person culpable?
Yeah, because they can figure out if it's ethical or not.
So they have resources, they can look and see if this is okay. They can figure it out. Should they be as culpable as someone who has 20 years of experience who told them to do it? So do you remember that addition to the Code of Ethics about bullying? That you cannot bully, you cannot have an abuse of power over anyone that you supervise? So in that situation, it depends. So it's not just an open and shut thing. This is kind of an ethical dilemma, and it's an ethical dilemma for the Board of Ethics too. When we say this is a new graduate who should have known better but didn't, they were influenced by this abuse of power situation, they were coerced to do this. So each case is looked at on an independent basis. It's not a yes-no situation. And that's why the Board of Ethics is comprised of 16 different people, so that it's not just one person interpreting this situation. And we'll talk in a little bit about how the Board of Ethics is situated and how those cases go. Okay, far, far away. Sally, who is a seasoned clinician, is located 150 miles from a location where she supervises Pam, who is a clinical fellow. During the professional experience, Sally informs Pam that she cannot continue serving as her supervisor, secondary to the commute time and travel cost. It's 150 miles away. Gas is expensive, right? So Pam offers to reimburse Sally for her time and for her travel expenses. Is that okay? Can the supervisor accept reimbursement of travel expenses from the conditional licensee? So the question is this an abuse of power? Is this putting an inappropriate relationship between the supervisor and the supervisee? Reimbursement for travel-related expenses are not prohibited under the Code of Ethics of ASHA. But they must consider options for supervision, so indirect and indirect. So can they Skype? Can they FaceTime? Can they talk on the phone? Are there ways that that will permit the supervisor to monitor Sally's performance, to improve it, to provide feedback, and evaluate Pam's performance in her professional appointment? So are there other options? Sally, who is the supervisor, has to respect the nature of the relationship. That Pam is very, very, very vulnerable because she's depending on Sally's input to make or break her career at that point. Okay? She cannot engage in activities that constitute a conflict of interest. So she can't say, I want you to pay my gas, I want you to pay for my time, and my car's not very good, so I'm going to need a new car, and I'm going to have to eat at Ruth Crisp every time I come to supervise you, because I'll be starving by the time I get there. She can't do that, because that makes Pam feel even more vulnerable, and it provides a conflict of interest. Well, I would have passed you on this clinical fellowship experience had you bought me a Jaguar. But instead you bought me a Pinto, so you're not going to pass. So that makes the relationship a conflict of interest, and that is forbidden. She also has to check with the employer to make sure that this relationship or this agreement is acceptable. So if it's a school system, she has to check with the school district to make sure that she can accept money for travel expenses and her time. If it's for a hospital, she has to make sure that it's okay, that it's not violating some rule that they have. She has to document the agreement. She has to include the nature, the time, the duration, the frequency of the supervision, as well as the amount to be reimbursed. It all has to be in writing. Any agreement that you make related to this should be in writing, because remember, just like in documentation for services, if you don't write it down, it didn't happen. This way you avoid any she said, he said language, okay? Keep a record, not only of the agreement, but anything that's paid or received. Make sure that you document the frequency, the duration, and the amount that you received to supervise. All right, missing in action. A clinician's employer measures productivity by the number of appointments that are scheduled each week. Not by how many were done, not by how many minutes, by the number of appointments that are scheduled. The clinician's productivity suffers secondary to personal issues and stress. Her mom got sick, the cat's sick, she had to take it to the vet. The kid had a play, so she had to go to the play, because what good mom doesn't go to their child's play? The grandparents are moving to town, lots of things are going on, and it's very stressful. She's got all these clients that she has to see, but she needs to put her family first, right? She just can't get to all these client appointments. But remember, her boss measures productivity by the amount of therapy sessions that are scheduled. So she reports appointments with these patients and clients that don't occur, just to meet those productivity requirements. She needs the job, and she can't have any less money per week because she's got all these expenses. I mean, she had to buy her person she's supervising a Jaguar, right? So she writes down that she's going to do them with full intent that she's going to make them up, okay? She even submitted documentation that she did these visits in order to get the billing. The person performs about the same every time, so she just made some stuff up. But she wasn't doing anything wrong, because she scheduled makeup visits, so she was going to go do them when she got time, right? She just billed in advance for what she was going to do, but she hadn't provided them yet, okay? Well, the spouse of one client called the office complaining that her husband had not received services in several days. So the office looks. The clinician had been out there 3 times that week already. The documentation was there. The billing had been dropped. So the clinician explains that she was going to make up the session. She really had the best of intentions. She's a nice person. She didn't intend to bill for services that she didn't provide. She wasn't like that. She was going to do them. It's the first time anything like this had ever happened. Really. And she would never do it again. Okay? She's a nice person. I mean, you went to graduate school with her. You know she's nice, right? She plays bunco with you. You know she's nice. It's the first time anything like this has happened. Come on, she really does have a lot of stress. And she really will make them up. Does an ethical dilemma exist? Is there a right or wrong answer for this one? Absolutely. Yes, she did wrong. So is this an ethical dilemma? No. Remember, an ethical dilemma is when there's no right or wrong answer. So what are the possible violations? What did she do wrong? Fraud. You cannot bill for services you don't provide, even if you have the best intentions on making them up. I mean, what if you get into a car accident on the way home? What if your house gets blown away by a tornado and you can't come to work? What if you have a GI bleed and you get stuck in the hospital for 2 weeks? You may not be able to make them up. So what violations other than fraud? Does this reflect poorly on the profession? Yes. Excuse me. Is this good interprofessional and intraprofessional relations? No, it's not. Okay. Caseload chaos. A full-time speech pathologist and her entire caseload, or a full-time speech pathologist retires and resigns. Her entire caseload is then transferred to the remaining full-time speech pathologist. Okay, so she quits, and so the school, the lead speech pathologist says, you know what? You just take her 53 kids. You can treat them too. The remaining speech pathologist goes to her chain of command and says, I cannot provide services to 122 kids. There's no way that I can do it. You can't add her caseload to mine. So the school says, you know what, you're right, you can't. There's just not enough hours in the day for you to provide individual treatment to 122 kids. So I'll tell you what, they're 5 days in a week, you're gonna work for 6 hours a day, break these kids up into groups of 15. And that way you can see them all. And the speech pathologist says, wait a minute. You want me to remediate this R with a child who stutters, with a child who has autism? I can't do that, that's not appropriate. The school says, yes it is, and you will do it. So the speech pathologist says, no, I won't. And so she got fired. She was subsequently fired for failing to provide the services. And the school turned her in for client abandonment. Okay? So can the school special ed director require the speech pathologist to provide services in a group setting if the speech pathologist says, this is not appropriate to meet my client's needs? No, they cannot. Was the clinician guilty of client abandonment? No, she was not. Summer sessions. A school-based practitioner has provided speech and language services to students on an IEP throughout the school year. At the end of the school year, the child's parents ask the practitioner to continue therapy with their child over the summer. The parents offer to pay privately for the sessions. Okay, so the speech passed all the person all through the school year. School's out. The parents really like this clinician. Can they offer to pay privately to continue services? What do you think? Does an ethical dilemma exist? So it depends on what. Are there other available services? So a lot of school systems have extended school service or extended school year, and they can get services that way. Is the relationship inappropriate? Is the money that's going to be exchanged the appropriate amount? This is how this is viewed by most school systems and by ASHA, is that speech language pathologists are permitted to accept patients in a private setting, okay? But the speech pathologist should make sure that their employer doesn't have a policy against that. So if the school system prohibits that and she does it anyway, she could lose her job. The speech pathologist should inform her primary employer the nature of this continuing relationship. Hey, I saw him throughout the school year. You don't have extended school year. I'm going to continue seeing him. Again, the cost should be established and documented. You have to write those agreements down. And then you have to document for those services just like you would in the school setting or in a hospital setting or wherever you received them, including the dates, the amount received, the duration, and the results of therapy. So in a hospital setting, how might this affect us? So if you have a patient that you saw through the hospital or through rehab, and then they're discharged, and the family says, hey, we really like the work you do. Can you come to the house and see our son twice a week? We'll pay you out of pocket to do that. Is that okay? You work in a hospital, you have a patient who's had a brain injury, and the family really likes you, They don't have insurance. They can't go to rehab. They need continued therapy. And the family says, we want you to continue seeing him on a private basis. Is that okay? Is that a conflict of interest?
Why can't they go to outpatient? Are there other resources they could have?
So someone says, yes, it is a conflict of interest. Someone says, are there other facilities or resources that they could use to obtain these services? And someone says, why can't they pay privately to go to rehab? So what do you think? Considering those things, is there an ethical dilemma? Absolutely. Absolutely. So that's unethical because there is that conflict of interest, because there are other options available. Now, what if it's a rural setting and there are no outpatient rehab clinics close by, and you're going to charge them less than a rehab would, and that's all they can afford? Is this an ethical dilemma, or is this an ethical violation? This is a dilemma. So what if you're the only speech pathologist in the county and this patient happens to be your cousin? This is a real situation. So what's the answer there? Is there a conflict of interest? Yes. Does your relationship as a cousin interfere with your ability to make objective decisions about that person's care? So what do you do in that situation? There is not another speech pathologist. There are no other options.
Can you do teletherapy?
Could you do teletherapy? What would you do? Is that an ethical dilemma?
Yes.
Absolutely.
What about if someone is homebound?
What about if someone is homebound is the question.
Like in a home health setting, they're in between their sessions and they offer you to continue them and they would pay you privately.
So the question is, what if it's an adult who's homebound and you've been seeing them on a home health basis for a home health company? They've used all of their third-party payer benefits, so they don't qualify for any more home health, but the family wants you to continue seeing the patient and they want to pay you privately. Is that an ethical dilemma? It's an adult who's competent, can make their own decisions. So what do you do? Call ASHA. So I'll tell you, if you call the ASHA Board of Ethics, they will not guide you in any ethical decision making.
Okay, so then we'll call you.
So the answer was call ASHA or call Tracy Grammer. So what do you do in that situation? I think you have to weigh out all the options. So we're going to go back to that strategic decision-making tree. You're going to weigh out all the options. You're going to say, what if I do this? Is there a chance that someone can interpret this as a conflict of interest? Is there a chance that someone can say, I was taking advantage of this person? Am I creating a vulnerable relationship where someone might construe this as an abuse of power?
Could it be then abandonment of care if all of a sudden you decided you didn't want to do that and you're not under any contractual obligation since it was your personal time?
Can it be construed as patient abandonment or client abandonment if you are not under any contractual agreement to continue seeing the patient and you stop abruptly?
Right, just because you're getting paid privately.
So this always brings to the question, if you have a patient who has, for example, Medicaid services, and Medicaid will pay for 15 services for adults as an outpatient. When that 15 visits is up, do you stop seeing them just because the money ran out? Is that client abandonment? And they still need the services. What's your ethical obligation? Sorry, you're out of benefits, we can't see you anymore. What's your obligation? To try to find other services. So in Oklahoma City, we're fortunate in that we have the Keys Clinic, we have the UCO Clinic, where people can go to receive other services. What about in rural areas? Is it client abandonment? Is this an ethical dilemma? Should we let reimbursement potential or constraints guide our recommendations for patient care? No, we shouldn't. Are we asked to do so by our employers? Yes, we are. It's like this situation where I was hired to be an expert witness in a wrongful death case a couple of years ago. And it was a dysphagia case, so it was an issue with someone who had dysphagia, and they were in a long-term nursing facility. And the person had had 4 CVAs. They had dementia, they had bipolar disorder, and depression. And so as I review these stacks and stacks of medical documents, I see that the speech pathologist would see the patient for 2 weeks and then dismiss for lack of progress. 3 weeks later, would pick the person back up and start seeing them again, as if some miraculous thing had happened and now they had a functional expectation of gain, or a reasonable expectation of gain. 2 weeks later, they would discharge them because they weren't making progress. 2 weeks later, pick them back up. And this went on for 4 years. About once a month, they would pick them up for services and then discharge them. And the goals were the same every single time. The goals weren't functional, they weren't really measurable, but they were goals. Why do you think that was happening? For what? Pressure to increase productivity to get payment. Is that an ethical violation? So do we let the demands of our employers guide our recommendation making for patients? So if you know that someone needs therapy 2 or 3 times a week, and they have this very limited 15 visits that Medicaid will pay for, what do you recommend? Do you recommend what they need? Do you recommend what they can get? How do you write that? How do you get around that ethical dilemma? Could you say something like, to maximize rehabilitation, speech pathology services are recommended 2 to 3 times weekly. However, due to third-party payer constraints, we'll see times 1 weekly and establish home programs. Does that get you out of hot water? Ethical dilemmas. All right. So here's what happened. Here's what happened in our summer session scenario. So the speech pathologist established an agreement with the parents to provide therapy twice a week with the appropriate fees. So commensurate with what the going rate was for other services. The speech pathologist provided therapy at the child's house, because where else is she going to see them? She works in the schools. She doesn't have an office. Okay? So the parents are very satisfied with the child's progress, and they really like the speech pathologist. And the interaction between the child and the speech pathologist are incredible. The child's language blossoms around the speech pathologist, which is natural because that's what we do, right? So they need to run a few errands. So they ask the speech pathologist if, while she's there, they can go and run a few errands. I mean, they're never in the room when she's working with the child anyway, so what's it going to hurt? So she says, okay. And they go run some errands during this session. And it starts to happen over and over and over. Okay? So then, after some time, they say, hey, you know what? We're all going to the zoo. We're taking a family outing to the zoo. Why don't you come and go with us? Johnny does so well when he's around you, and we want to maximize his experience at the zoo. Just come and go with us. Is that an ethical dilemma? So she goes, and they have a great time. And they do naming, and they elicit articulation, and it's great. It's like a therapy session. Well, some weeks later, the parents ask the speech pathologist if she'll babysit Johnny, because they are exhausted. They've got 3 other kids. Johnny takes a lot of attention, a lot of energy, and they are worn out, and they need a date night. They'll be better parents if they have a date night, right? So they want her to come and babysit Johnny and the other 3 children. They know her. She's been coming by the house all summer. Does an ethical dilemma exist? Which part? The running errands, the going to the zoo, or the babysitting? What potential ethical dilemmas exist? So what's wrong with this? If you've ever worked home health, you know this happens. You have an elderly man and the wife is having to do everything. She can't find time to go to the grocery store. She can't find time to get her hair done. She's exhausted. Please do you mind if I run to the grocery store? Do you mind if I go get my hair done? Hey, you know what? My kids invited me to a play. Would you mind coming by and doing your session so I can go to this play with my kid, do this session late at night? Hey, he's having a birthday. Meet us at this restaurant for his birthday party. It happens. It doesn't just have to be in a school setting. It happens in home health. It happens in private practice. A patient today asked me, when he has his 80th birthday party in a town far away, would me and my husband and my son please come and join him? It's going to be this great festival at this lake house. Please come. Does an ethical dilemma exist? What? What's wrong with it? Relationship, inappropriate relationship, but what else? How about exploitation of power in a vulnerable relationship? Because whether we think so or not, we stand in a position of power over our students or our clients or our patients. They look up to us. And someone could construe that their therapy or the recommendations that we were made were affected by these outside relationships. Okay? If anyone could ever step back and say, is this happening? If someone could assume inappropriateness on something that you're doing, it's inappropriate. Okay? Always remember that rule. $1 short and a day late. So a speech pathologist who works for a contract company has been assigned to cover 3 skilled nursing facilities, which is not unusual. Okay? Many times he does not have time to complete the documentation for each patient on the day of service. He does, however, complete the documentation within 24 to 48 hours of service delivery. So he gets the notes done. He keeps a log, he does great response recording, and he writes the notes. Okay? And the notes are accurate. He gets them done within 24 to 48 hours. How many of us ever see patients and have to leave before we finish our documentation and do it the next day? It happens. We do it. So the documentation for this contract company is completed in an electronic medical record, which many healthcare facilities, home health agencies, and private practices now use. Okay? So the date of documentation, as you guys know, is established when the note is open. So if you write the note 2 days later and you open the note, the date that's on there is the date where you open it. Okay? If the clinician who's documenting does not purposefully or intentionally change that date, then it stands as the date that it's open. So if you're writing a note that's in arrears, you have to change it to reflect the date of service. Okay? So this speech pathologist was in a big hurry. So he hurriedly but accurately and thoroughly completed his documentation. It was a great note. It was thorough, it was accurate, that he provided yesterday. Okay? He signed the notes. So the charges would cross into the billing system. He failed, however, to intentionally change the date of the note. Is there a problem? It was accurate, it was thorough, it was complete.
Yeah, if he was seeing somebody else at that time instead of this person.
So if he was seeing someone else at that time instead of this person, well, the note was accurate, it was thorough. The date was wrong.
I know, but I'm saying that he was seeing somebody else on the date that he put the note.
Oh, okay. So if he was seeing someone else at the same time when this note was dated. Here's the problem. One of the patients for which he documented discharged to home the previous day. So the same day he saw him, this patient discharged to home. He opened the note the next day, did the note, didn't change the date. So it looked like he dropped a bill or he billed for a service the day after the patient discharged. Does an ethical dilemma exist? It's a one-time mistake. He forgot to change a simple date. He provided the service. What he wrote was accurate, but he didn't change the date. So is that fraud? Did he bill for something that didn't happen? What do you think?
Yeah. He billed that for the day that he was already discharged. So yeah, it is.
So everyone's saying yes, because he billed for the service that was on the day the guy discharged. The real situation in this is that the man died. So then the bill dropped, and it looked like he had billed for services that he didn't provide, and the man had passed away. So what steps could he take to minimize this risk of this occurring? What?
Type a note of the day of.
Type a note the day of. Do your documentation as you go, which is sometimes easier said than done, because life happens and we get busy. Due diligence, attention to detail. Clocking in for hire. So an audiologist working in a clinic must clock in and out each day. He lives 40 miles from the clinic. Traffic is unpredictable. The weather gets bad. Sometimes there are accidents. You never know. Sometimes it's 40 minutes, sometimes it's 60 minutes. You never know. So he's frequently late for work. Okay? So after an action plan to improve his timeliness has been instituted for his work arrival, the audiologist made an arrangement with his coworker. An arrangement. Okay? So each night the audiologist would leave his name badge on the desk. If he wasn't there by the expected arrival time, his coworker would clock in for him. The audiologist would pay the coworker $20 a week to do this very simple task. Now hang on, don't judge. Don't judge. He's not a bad guy. He's not stealing company time, because he frequently clocked out for lunch but continued to work off the clock. So he was working for free, right? So surely he was making up those minutes in the morning. And then he always stayed late and worked off the clock afterwards to get his documentation done. And they weren't paying him to do it. He was working more than the minutes that he was late. Does an ethical issue exist? What's the issue? It's fraud. It's fraud. Open and shut, that's fraud. For whom does the ethical issue exist? Is it the coworker or is it the audiologist? It's both. So in the facility where I work, if you're caught clocking in for someone or you ask someone to clock in for you, you can be fired. You'll be terminated. So where I work, there was a nurse one time who would not clock out, but she would leave and then come back, but not clock out for lunch. And so they thought this was happening, and so they pulled the parking gate records where you badge in to park, and they compared it with her time records. And sure enough, there was a big discrepancy. So she was terminated. It's fraud. It's also corporate theft, and it's illegal. All right. We want therapy. So a special ed coordinator of a school and a principal approached the speech pathologist about qualifying a student to receive services on an IEP. The special ed coordinator and the principal indicate that the parents are very insistent and that their child should receive services under this IEP. There are some VIPs from the community. They have a lot of money and they want their child to be seen. They're VIPs. They're big donors to the football program. Don't laugh. It's important, okay? The child is only exhibiting issues in articulation. So that's not enough to qualify him for school services on an IEP. So the speech pathologist says, I'm sorry, he doesn't qualify for services. So the principal indicates to the speech pathologist that the parents might sue the district if the services are not provided, and the principal really does not want negative media publicity, especially from these VIPs, because they are such big donors to the football program. It's one child. He does have articulation problems. It's one child. What should the speech pathologist do? Not provide the services? What if she gets fired? Does she have any recourse? What would that recourse be? To maybe go to the school superintendent? What could she do instead of providing those services? Find other services, another referral source. Discuss it with the parents, maybe private practice. Should she offer to see the child in the home? Maybe go to the zoo, do some babysitting? No, no. What ethical violations may exist if she sees the child?
It's abuse of a vulnerable
So someone said it could be construed as an abuse of a vulnerable relationship. So who would be the vulnerable person?
The school.
So coercion in the workplace, and if the special ed coordinator or the principal could be viewed as taking advantage of that vulnerable relationship with the employee who's the speech pathologist. So what ethical violations could exist if she does provide the services and the child really didn't qualify? Fraud. Are they adhering to state regulations and federal regulations? No, because federal and state regulations say what qualifies a child to be seen for services under an IEP. Okay? So if she fudges the data to qualify this student for services, then she's misrepresenting, she's committing fraud, and she's not providing services competently. All right, so the speech pathologist has to respect and protect the inherent worth, integrity, dignity, and rights of the child. So what's best for the child in this situation? The speech pathologist can only accept a client for treatment who will reasonably gain from those services. The speech pathologist has to exercise her independent judgment and clinical decision making regardless of the referral source or the prescription. So in the medical setting, how could this affect us? Or as in an audiology setting? If someone says, I'm going to refer this patient to you and I want you to see them, and you don't think that they're going to benefit from services, do you see them? It's a really important doctor. They send you a lot of patients, and he wants his elderly mom to be seen for services. And you're afraid if you don't see them, he won't send you more referrals. So you kind of feel like you have to, right? Is that the right thing to do? Is that an ethical dilemma, or is it open and shut?
She doesn't need service.
Open and shut if there's not a reasonable expectation of gain. Okay. So what options does the speech path have? And we talked about this. Establish a home program for the person, for the parents or the children or the spouse to implement. And then provide resources for other clinics. So maybe you could take them to this private clinic, or maybe you could call this home health agency, something like that. All right, test score transposition. A seasoned clinician, like 45 years, who's a very well-respected clinician, has a caseload of 76 children. This is a true scenario, okay? So she tested all of the children at the beginning of the semester, established their eligibility, and established IEPs for each child. But the parents of Vera were not satisfied with the progress that she was making in therapy. So they sought a second opinion through a private clinician. So the test scores supported the findings of eligibility. So they agreed, yes, she's eligible for services. But still the parents were not satisfied with her progress. They said something's not right. So they requested the records and the test protocols to compare scores to the test report, which is typically not done. We typically don't let parents have our test protocols to look at because we don't want them training the student to the test so that the next time we test the student, they'll have memorized the test. So that's not typically something that's done. But the parents were given the test protocols and they saw the scores. They discovered that the numbers of one subtest had been transposed. So instead of saying 74, it may have said 47. So when she calculated the composite score, they had been transposed. This transposition, however, did not change the eligibility of Vera for services, nor the focus of the IEP. It didn't change anything. But the parents filed a complaint with ASHA against this practitioner for incompetent practice, saying that her age was precluding her ability to provide services competently. Does an ethical issue exist? Didn't change the scope of therapy, didn't change the IEP or the eligibility. Does an ethical dilemma exist? So ASHA found that so when we originally got the case, all we got was the information from the parents. And so the person who reviewed it recommended a sanction. because she should have known how to administer and write down these tests. So on the Board of Ethics, if a complaint is filed against you, we don't investigate cases. So all we have to go on is what's given to us. And so if you file a complaint, we get your information, and the person, the alleged wrongdoer, is allowed to give information too. At that time, the person has to prove that they didn't do it or that the allegations are incorrect. If enough information is not provided, what we have to go on is what we have. And so they found that the person would get a sanction. So she came back to ASHA on a further consideration hearing and presented her case in person. And by the time she left, we all wanted to hug her and say, we know you just made a mistake. And so the case was dismissed. No ethical violations exist in this case. Okay? That's a simple human error. So simple human errors are covered under the Board of Ethics as recognizing that this is a one-time error. Okay? Absent-minded audiologist. So an audiologist forgot to renew his license by 12/31 of 2017. He performed just two, audiometric evals on January the 2nd of 2018. No one works on the 1st. So the first day back, he does only 2 evals. And then he remembered that he forgot to renew his license. So at 8:04, he calls the licensure board and he renews his license over the phone. And he goes online and renews it. 8:04, it's done. 1-3. Okay? He is employed at a local ENT clinic and bills Medicare and other third-party payers for his services. Now the state licensure law says you have to be licensed to bill Medicare. You have to be licensed to practice audiology. Does an ethical dilemma exist?
Yes.
So some people say no, some people say yes. Okay? State law says you have to be licensed. So when you fail to renew your license on December 31st, it's not that your license is late, it's that your license is expired. It's just like your driver's license. There's no grace period for your professional license, okay? It expires December the 31st. On January 1, you are no longer licensed. So he called the state licensure board and asked if the licensure board would please date his license 1-2 instead of 1-3. Come on, be reasonable. It's 1 day. 1 day. You don't have to be like that. You can be nice. You could post-date my license. So he provided the following rationale. I've been an audiologist for 18 years. I have never renewed my license late. Never, not once. It's usually early. And I only did 2 evals on that 1 day. It's no big deal, right? Does an ethical dilemma really exist? Why can't you just be flexible and retroactively renew my license? No harm was done to anyone. I did what I said I did. I billed appropriately. I provided good services to these people. Why can't you be flexible? Does an ethical dilemma really exist? Does it? Absolutely, the law is the law, and it says you cannot practice speech pathology or audiology without a license. December 31st, that license is expired. Every year, OBESPA hears more unlicensed practice cases than anything else because of this issue. We have people that have practiced for 30 years who forget to renew their license because they were sick or someone in their family was sick, or because they were moving or going through a divorce, or they were on a cruise for New Year's Eve and they just didn't get around to it. But when they came back to work, they hadn't renewed their license. So as long as you don't see any clients or patients before you renew it, you're okay. But you better not see one single client without. So if you want to know what happens, you are required by law to not bill those patients, or if you've already billed them, to refund all of the money to Medicare, Medicaid, to whatever the payer source is. You have to refund that money and drop the charges. So we've had cases where clinicians coming out of their clinical fellowship year didn't realize that they had to renew on 12/31. that their license expired exactly like everyone else's. And so once they finished their CF, they didn't apply for full licensure or they didn't renew it. So we've had cases where people have practiced for 7, 8, 9 months without a valid license. Because you're licensed as a clinical fellow, when you finish that, you then have to apply as a licensed speech pathologist. If you don't change and apply for full licensure, you're practicing without a license. And so what happens in that instance is the speech pathologist or the employer has to refund all of the money that was billed. And it just so happened that the two of which I'm thinking worked for skilled nursing facilities. And as you know, they bill on tiers. So all of the charges for PT, OT, and speech are rolled into one, and they bill in a tier according to how many minutes of service they provide. So when they redact the speech charges, it takes them out of that tier because not as many minutes were provided, and the skilled nursing facility then has to bill under another tier. One clinician was $76,000 that had to be repaid, and the other was $38,000. So it's a big deal. And so who has jurisdiction at that point? Well, we can say you have to refund the money. So what happens is notice gets sent to Medicare, Medicaid, and then Medicare, Medicaid takes over. It's a big deal. You cannot practice without a license. Sloppy supervision. A speech pathologist has been assigned to supervise a speech pathology assistant in a rural school 47 miles from her own school. 47 miles. She has a caseload of 52, and the speech pathology assistant has a caseload of 37. The speech pathologist has never supervised a speech pathology assistant before and doesn't really want to. So the speech pathologist and the speech pathology assistant meet and establish an agreement and a schedule for supervision to include both direct and indirect supervision modalities. The first semester works efficiently without any issue, goes off without a hitch. Everything is working great. The speech pathologist trusts the speech pathology assistant. She knows she can do a good job. In the meantime, the speech pathologist has assumed care for her elderly parents, which stretches her time even more. She begins to cancel the scheduled supervision meetings on a regular basis. Cancels, cancels, cancels. So the speech pathology assistant knows she needs to be supervised. So she emailed her supervisor, but the supervisor still kept canceling and didn't make up these meetings. No changes occurred. So the speech pathology assistant had no choice. She began to attend IEP meetings and to perform therapy to modify the IEP as she saw appropriate. So by law, a speech pathology assistant cannot change an IEP, okay? So the speech pathologist trusted the speech pathology assistant to perform these tasks and to provide the treatment that the children needed. She was doing a great job. I mean, there's no question about her service delivery. She had supervised the speech pathology assistant on numerous occasions and found her skills to be exceptional. She planned to supervise the speech pathology assistant on a regular basis once things settled down. She was going to do it. She knew she was doing a good job. She just couldn't do it right now. So do ethical dilemmas exist? Okay? For the speech pathologist, for the speech pathology assistant. But she had no choice. These kids needed their service. How about for both? Does it exist for both? So what should the speech pathologist do? If she knows she can't make these meetings, she can't provide the supervision that's required, what should she do? Find another supervisor. What about the speech pathology assistant? Find another supervisor. So should she change the IEP? Absolutely not. Absolutely not. Okay, I was in a hurry. So a speech pathologist works in a medical system which uses electronic documentation. She provides therapy to 14, 15, 16 patients a day, as well as modified barium swallows, cognitive evaluations, and fiber optic endoscopic evaluations of swallowing. The department director is not a speech language pathologist. She doesn't really understand the behind the scenes the non-billable stuff that it takes to do the job of a speech pathologist, such as family education, posting of swallowing precautions, discussions with nurses and physicians about swallowing evaluations, and how to maximize communication with that patient. So the director requires 90% productivity. Overtime is not allowed without exception. There is never a case where overtime is allowed. The speech pathologist provides quality therapy and treats every single patient on her caseload. She's been counseled multiple times about having overtime for the past 2 pay periods. In an effort to avoid this overtime, but complete the documentation as required, the speech pathologist recalls the data from the previous sessions without changing it. So in an electronic system, you can advance through a note and just pull in what you wrote the last time. She has to get her documentation done. She has to meet her productivity. She cannot get overtime. So the next day, the speech pathologist had an appointment after work and needed to leave at exactly 5:30. So she again recalled the previous note with the intention of correcting the information when she got caught up. The speech pathologist suddenly became ill and required hospitalization. Another speech pathologist covered those patients, came in, and started reviewing those notes so she would know what to do with each patient. As she reviewed the previous notes in preparation to treat these patients, she noticed the redundant information in note after note after note and reported it to the supervisor. Does an ethical violation exist? She did the therapy, she did the documentation. She just didn't change the documentation to reflect what she had actually done in each session. What's the ethical violation?
Inaccurate reporting.
Inaccurate reporting, falsification of records. Okay? But the speech pathologist planned to correct them. She had every intention to correct them. Isn't this sufficient to erase any violation? Absolutely not. It's not what you intend to do, it's what you did. Okay? So a stitch in time saves 9. Be accurate, be timely, and be thorough. Integrity. Do the right thing all of the time, even if no one is looking. Not thinking, oh, I won't get caught. If a tree in the forest falls, can anyone hear it? It doesn't matter. Do the right thing all of the time, every time, and there will never be an occasion where you may be in violation of the Code of Ethics. Document every single thing you do and say thoroughly and in a timely manner. So I was called before a court one time when one of the trauma patients at the facility in which I work sued the person who hit them. And it just so happened that I was covering on a weekend and was asked to do a cognitive evaluation to see if this person could go home or needed to go to rehab. So I administered a standardized test. And thank goodness that I did, because I had that documentation to back me up 5 years later when I was called into court to testify about what I had written and recommended for this man. So as I'm testifying, and the attorney is badgering and just trying to get me to break on what I had recommended and what I said and what I recalled, I could say, no, I documented that day thoroughly what I had done based on a standardized test. I didn't let anything sway my recommendations or my diagnostic statement for this patient. So you never know when you're going to be called to look back on what you wrote as true and accurate. You never know when you're going to be called on the carpet about a potential ethical violation. So when you do something with a patient, when you say something with a patient, document it thoroughly, accurately, and in a timely manner. And do not settle for mediocrity in your patient care, in your interaction with physicians and nurses, in your interaction with patients and families, and in your documentation. Because when you settle for mediocrity, you compromise your standards. Someone is counting on you to help him, to help her, or to help their family member, to be the expert, and to make the recommendations and to provide the treatment that they need to make to get better, to return to their life.
Can some of these,
Go ahead.
Can some of the ethics involved, the ethical dilemmas involved in that also about the number of patients that they have, that she has?
So in this example, the question is, let's see. In this example, the question is, can there be an ethical dilemma based on the number of patients that this person is required to see each day? So the number was 14, 15, 16, sometimes going up. So can an ethical violation exist? So what do you guys think? What could the ethical dilemma be?
Not quality of care,
Lessening the quality of care?
not having enough time to see all the patients.
Not having enough time?
Being dictated by management what you should be doing when they're not in your like scope of practice.
So being dictated by management who's not in the profession to provide services
That you deem not appropriate or
that you deem not appropriate or outside of your scope of practice. So does this go to interprofessional relations? Are there potential ethical violations? Absolutely. So you should only see a patient for services for which there is a reasonable expectation of gain. So if,
See those patients because there's not enough time.
say that one more time.
If you can't see patients because there's not enough time.
So what if you can't see those patients because there's not enough time? So for whom does that ethical violation exist? Is it for you, the clinician, or is it for the person insisting that you see all of those, knowing that they're not getting seen? It's for the person that dictates that you see that many patients who realize that they may not get seen for an adequate amount of time to make reasonable gain toward their goals. So what do you do in that situation? So you have to report to your chain of command. And so when you report to your chain of command, you go to them with viable options to remediate that problem. And you document, document, document. You keep a list of every time you go and tell them, and if nothing changes, then you go up the chain of command. And unfortunately, that's a tough one, and that brings us right into our next slide, which is ethical tricky spots. So these are tricky spots. Self-reporting. When you do something wrong, do you want to turn yourself in? Because maybe no one will know. Maybe you got picked up for a shoplifting charge. Is anyone really going to find out unless they read the tiny section in the back of the newspaper? Or it shows up on Facebook. Is anyone really going to know? Why do you have to self-report that? Does that affect your ability to practice as a speech pathologist? Does it reflect poorly on the professions? Is there something else going on? Some psychological issue that you might be going through or a personal crisis that might carry over into your workplace? Do you self-report that? Or let's say that you get sanctioned by your state board. Do you self-report to ASHA? If you don't and the state board turns it in, you're going to be held liable for that before ASHA's Code of Ethics or ASHA's Ethics Board. Unintentional violations. I didn't mean to not change that date. Is that really a violation of the Code of Ethics? I didn't mean to transpose those two numbers on that test protocol. No one got hurt, no one was injured. Is that an ethical violation? Reporting a peer or a coworker, going above your boss's or your supervisor's head up the chain of command to report an ethical violation. I don't want to report her, she's my friend. We went to grad school together. We were tri-delts together. We were in grad school together. No one else in the department will like me if I report her. It's a very small community and everyone knows everyone. I don't want to lose my job. How do you do that? How do you solve those dilemmas of reporting your friends? We're bound by the Code of Ethics to protect the integrity of our profession, to hold paramount the welfare of those that we serve, and to do what is right and not do what is wrong. So, questions? Yes?
What about the situation kind of reverse, where you feel like the patient can continue to benefit, but the agency may dictate that you cannot continue?
So the question is, you feel like the patient could continue to benefit, but the agency says you have to discharge them.
Right.
So why would the agency say you have to discharge them?
Well, Medicare or
So financial restrictions. So that's what we talked about when we were talking about making recommendations for patients. So if you think the patient can continue to benefit from services, but there is no more payer source, do you change your recommendations and discharge the patient even though you think that they could make progress? So what's going to happen if you don't discharge the patient and the payer source ran out? What's going to happen? Who's going to get the bill for those services? The patient. So at that point, you leave it up to the patient and say, you know, you're out of Medicare benefits. If I continue to see you, you're going to get the bill, and let the patient decide at that point. It's the same thing with these patients for which Medicaid will pay 15 adult visits. If we see them beyond that 15 visits, they will get the bill. So you leave it up to them, or you find other options for them to get services. And unfortunately, healthcare is a business. In 2018, healthcare is a business, and don't be fooled by anyone saying we're not for profit, we just want to help people. Healthcare is a business, and it's in business to make a profit. The underlying or overarching principle may be to help people, but it is a business, and it has to be solvent or they can't continue to provide the services that they do provide. And so there is a bottom line for all of those agencies, and that drives a lot of those decisions. At what point do we let those business decisions affect our recommendations? I think in this era of healthcare, it's incumbent upon us to have knowledge of other community resources to offer our patients so that they can have this continuum of care in the light of limited financial resources. So a long time ago, when I got out of school, which I call the coma to college years of rehab, we didn't have to worry about reimbursement. You know, you got what you billed for, and you wrote one note a month, and you got to see patients for years and years and years. Unfortunately, it's not like that anymore. And so it's incumbent upon us to be smarter about what we do with our patients and how we use the available resources they have, so that in the end, we're not faced with these ethical dilemmas. So is there some way I can incorporate this family into my treatment plan so that when I'm not there or when my services have to stop, they can continue doing the therapy? Can I find local resources for reduced cost services, like the John Key Speech and Hearing Center? In Tulsa, there are a lot of places where they don't bill for their services, it's all pro bono. So I think it's incumbent upon us in this age of healthcare business to know how to use the visits that we have wisely and to train the family to continue in our stead. Not saying that the family can take our place, but there are certainly things that they can do to advance the patient's functionality. Okay, so let's talk a little bit about how the ASHA Board of Ethics is comprised. So the ASHA Board of Ethics has 16 members. There are 8 audiologists and 8 speech pathologists. There's a chair and a vice chair, and so they preside over the meetings. There's a director of ethics who is an attorney. There is also a paralegal, and there's ASHA staff officer who represents the business of ASHA. The paralegal keeps us legal, and the director of ethics guides our decisions as to what we can do legally and what we can't do legally. Helps us to weed through some of the legalities that we get from the state boards. So people that are on the ASHA Board of Ethics are not elected, they are appointed by the board of directors. We serve 4-year terms. And so what happens is, as we receive cases, they're assigned to reviewers. So of the 16 people on the Board of Ethics, 4 of them in their 4th year serve as the Educational Ethics Subcommittee. So they help to revise ASHA's position statements on things like the use of speech pathology and audiology assistants, on the implantation of tracheoesophageal voice prosthesis. Anything that speech pathologists and audiologists might encounter, the ASHA Educational Subcommittee drafts the position statements. And they also revise the codes of ethics. And then the whole Board of Ethics votes on those changes. So the other 12 people are the adjudicators for the cases. So as ASHA receives a case, and they may receive a case from an individual, from a clinician, from a family member, or from a state board. So a lot of state boards, as they issue sanctions to license holders, they automatically send those cases to ASHA, as they should. Then ASHA assigns, the chair and the vice chair assign that case to an adjudicator. So like I said earlier, we are not investigatory, so we can't investigate any case. We go on what we get. So an offer is extended to the alleged wrongdoer to provide documentation that says, I didn't do that, that's not what happened, here's what really happened. So the adjudicator then takes all of this information and they look through the code of ethics and they find any possible violations of that code of ethics, and it's all listed. And then they propose a sanction. So do we do a private reprimand? Do we do a public censure that's published in the leader? Do we suspend the Cs? And if so, for how long? Minimum of 6 months. Or do we revoke the Cs, which will require the person to come back to ASHA and apply for the Cs again, having to meet the current standards, having to retake the praxis, having to meet the current educational and clinical experience standards. Okay? So after the adjudicator prepares all of that information, when we meet 3 times a year for 4 to 5 days at a time, that case is presented to the full board. The board will deliberate. So let's say that it's my case and I propose that we revoke someone's Cs, lifetime revocation, because this speech pathologist spit on the ground in Oklahoma, and as we all know in Oklahoma, it is illegal to spit on the sidewalk, and that's a truth. So the speech pathologist was walking down in Bricktown, spit on the sidewalk, which is illegal, which reflects poorly on the profession of speech pathology. So I say, let's revoke the Cs for life. So the rest of the board says, wait a minute, Dr. Death, you're being too harsh on this person. So we need to not revoke, let's just do a private reprimand. Or they say, this is a bunch of baloney, we're gonna throw this case out. So the case is deliberated and it gets heated and it goes back and forth. And if someone proposes a sanction and most of the board's on board and there's one person who says, wait, that person didn't spit on the sidewalk on purpose, they had a cold or they swallowed a bug and they were trying to get it out. Please be nice, be nice. Don't take away the Cs. Don't take away the ability to earn a living, go to the store, buy cold medicine to get rid of the cold so they won't have to spit on the sidewalk, okay? So it goes back and forth and finally it goes to a vote. And it gets heated in there. And there are champions for each case and people that are champions for the other side. It gets very heated and they're taken very, very personally because we realize that the ability to work affects people's lives. And it affects their ability to provide for their families and to have a house and to have a car and pay their electric bill. But more than that, we realize that taking someone out of practice pulls clinical services from people who desperately need them. And the last thing that the ASHA Board of Ethics wants to do is to prevent someone from providing those services to people that need them. So it goes back and forth and a decision is made. Sometimes you go away happy with that decision, and there are 3 or 4 cases that I still get kind of fired up about because it didn't go the way I thought it should go. And I'm not going to tell you if I'm the Dr. Death on the board or if I'm the softie on the board. It really depends on the type of case. So what happens then is that notification is sent to the alleged wrongdoer that this is the decision that ASHA made. If the person disagrees with that, they have the right to appeal in a further consideration hearing. So I'll give you an example of this. I had a case where a lady worked in a rural setting in a state where there aren't a lot of medically based speech pathologists. And so she worked in a hospital. She had 30-something years of incredible tracheostomy experience. She worked with trach tubes all the time. And she saw this patient in the hospital. In this hospital, then she saw him in this hospital. So when the person got out, the parents said, could you please come and see him in the home? So the mother said, I think he's not breathing well with this trach tube. Could you please put in this trach tube? I've looked on the internet, I've Googled him, I want you to put in this trach tube. So the speech pathologist says, sure, I'll have the doctor's office order one. So the doctor's office orders that trach tube, the speech path gets it, and she goes to the house and she's going to put it in. So she says, I need to suction this person. And the mother says, no, I just suctioned him 30 minutes ago. It upsets him. I don't want you to do it. So the speech path says, okay. So she pulls out the fenestrated trach tube, and there's resistance. And the mother won't let him suction. She pulls it out, and there's a little bit of skin in the window or the fenestraw. So she puts the new trach tube in. The mother won't let him suction, but he's doing fine. His O2 sats were, we don't know what they were because she didn't take them. Okay? So she doesn't know what they are, but he's doing fine. He's breathing fine. He's not acting like he's in respiratory distress. He's doing fine. So flash forward 2 days. She gets an email from the mother that says, by the way, you put in a pediatric trach tube. That is not the one I wanted, and we had to go to the ER. I'm filing a complaint against you. So she files a complaint with the state, and the state says, whoa, speech pathologists cannot work with tracheostomy tubes. In each state it's different, and it's according to your workplace. Because the Code of Ethics says we can do nothing for which we have not been trained and found to be competent. So they say you can't work with trach tubes, but we're not going to take away your license. We want you to practice because you're a good clinician. But you can't see patients with trach tubes anymore. You can't work with Passy-Muir valves, you can't work with any other speaking valves, and you certainly can't work with a tracheostomy tube. Well, this is very detrimental to this rural area. And as many doctors testified, she's the only person who does this. So it comes to us, and it's my case, and we make a decision. And the only thing that we want to do is a public censure. No, no, no. And we do that not to say to her, you can't work with trach tubes, but we do that to show people that even though you're an incredibly competent, well-trained speech pathologist or audiologist, and you have all of this knowledge and experience, don't cut corners. You have to have due diligence with every single patient, and don't get sloppy because you're very comfortable with your knowledge base. So she disagreed with this, but what she disagreed with was that we didn't take away the state sanction that she can no longer work with people with tracheostomy tubes. We can't overturn that. So it comes back on a further consideration hearing. So what this means is that now she has the opportunity to come before us, to bring new evidence, and to come before us as a board with an attorney if she so chooses, and present her case. So the Board of Ethics upheld the original sanction. Public censure. Published in the ASHA Leader, don't do this again. We don't restrict her Cs in any way, but we can't reverse what the state said. And I said to her, what is it that you would like to see us do? What would you like the ASHA Board of Ethics to do? I think I should be able to work with patients with tracheostomy tubes. So you understand that ASHA does not have jurisdiction over your state. That if the state levies a sanction, that sanction stands in your state unless they revoke it. Because we can't take away what we did not impose. Okay? So if you have a driver's license for Oklahoma and you go to New Mexico and you're driving crazily, they can't take away your Oklahoma driver's license. They can give you a ticket, but they can't take away your license to drive because they didn't issue it. Okay? We cannot take away what we did not issue. So she was very upset. She never understood this. So we say we're going to uphold what we originally proposed. Public censure. That's it. So then it goes to the Board of Directors on further appeal. And the only thing that will do is to look back at our transcripts and to read the transcripts and listen to the audio recording to make sure that we did everything we were supposed to according to the letter of the law, according to ASHA. So the Board of Appeals upholds our decision. She's still upset and still doesn't understand that we cannot give her back the power to work with tracheostomy tubes. So what could have changed her case? If we had documentation from the hospital that the trach tube was actually was an adult tube and that the patient was not harmed, because she kept saying that nothing happened to him, but nothing happened to him. But what if? There are those preventative ethics. What if he would have had uncontrolled bleeding? How do you know he didn't have uncontrolled bleeding? What was your backup plan if he would have bled? Were you going to insist that you suction? Did you wear protective equipment? Did you wear gloves? Did you wash your hands? We don't know because it wasn't documented. And she didn't provide that information when she came back. So if a complaint is filed against you and you get it and you say, this is not true, absolutely not true, I shouldn't have to defend myself. I'm sorry, but you do. Give them 100% of that information. And what information are you going to give them? The thorough, the accurate, and the complete documentation that you did on the day of service with the correct date, with the correct patient name, so that you have information to back up what you're saying. So that's how the Board of Ethics works. Does anyone have a question about the Board of Ethics? How do you get on the Board of Ethics? Does anyone know?
Did you say you get appointed?
You get appointed. How do you get appointed? Someone that you know, but what it takes is that fill out those committee volunteer forms. So those forms stay in the ASHA system for 3 years. But I will tell you that the squeaky wheel gets the grease. If you want to be on the Board of Ethics, and that's the board you want to be on, every single chance you get, you go onto that website and you say, click, I want to serve on the Board of Ethics and I would be good because I am Dr. Death. Or I want to ensure, equitable and equal application of the law to all speech pathologists to protect those that we serve. You can, say something very eloquently, but the more you do it, the better of a chance you have of getting on an ASHA committee or board. So that's how you get appointed to the Board of Ethics, and they will say, will you serve, 4 years? Will you come to the national office 2 times a year for this many days, and then go to the ASHA convention for this many days ahead of the ASHA convention and serve on the Board of Ethics that way. Okay? All right, does anyone have a question, an ethical dilemma? Okay, let's talk about this one just for a second. So this is an egregious one that most people do not believe happened. So there was a speech pathologist, and I can talk about these because they've been published already. So they're public record. They're not still ongoing investigations or cases. So a speech pathologist was the director of a hospice. And as her role as this director of hospice, she had a client who was very wealthy, who was married to a man. They had 1 child. She ingratiated herself to the husband and the wife. The wife passed away, and she continued her relationship with the 96-year-old husband, 96. She became the sole beneficiary of his estate. And as the relationship continued, she became the executor of his estate. And he had a very large estate, okay? So he had a lady who was his personal attendant who didn't speak English very well. And so they had someone go to the house and say, in her native language, that should something happen and she should say anything, she and her family members would be taken back to their native country and something would happen to them. So a couple of days later, the speech pathologist goes to the house. The man is in the house eating at the table. She calls the attendant outside and she says, "Isn't it so sad that he is without his wife? He loved her so much. Wouldn't it be better if they could be together?" "Oh, yes, it would. Oh, that'll be a joyful reunion," all of this stuff. So then the speech pathologist says, "I need you to stay out here and talk to me for 45 minutes.
Oh my God.
You are not to go back in the house for 45 minutes. So around them goes someone else. And he comes up behind the 96-year-old man and he smothers him with a plastic bag. And the 96-year-old man dies. The man leaves. The speech pathologist continues to talk to the personal attendant and then leaves and says, "Remember, do not go in the house for 30 more minutes. We're watching." So the housekeeper goes in and there he is dead. But he looks like he died of natural causes. So they have a funeral and they bury him. The housekeeper's sense of morals and ethics and the law start to take effect, and she feels terrible. So she goes to the authorities and she reports what's happened. So they exhume the 96-year-old and they find that, sure enough, he's been asphyxiated. So why in the world would that case, that's very obviously a legal matter, come before the Board of Ethics? So before we answer that, let's talk about another one. There's an audiologist who was a very good audiologist. And he also knew how to do books. So he told the practice owner, hey, I can save you some money. You don't need to hire a bookkeeper. I can handle paying your bills. So he pays the bills and he does a great job. Slowly but surely, he starts writing himself checks. $500 here, $1,000 here, to the tune of $12.5 million. A little bit at a time, nobody notices, right? So finally, someone figures it out. When the IRS came and said, hey, you're not reporting $12.5 million in income. Where is it going? So they figure it out, and it's the audiologist. So he goes to prison for 2 years. White-collar prison somewhere in sunny beaches in Florida. And he gets out. And he goes to psychiatric counseling. And it turns out that he has a low self-esteem. And he needed the money to buy gifts for his friends because he needed these friends. Okay? So justification. So he goes to counseling and he comes back and he says, I want to be an audiologist. I love to help people. My self-esteem issues are fixed. I want to be an audiologist. So open and shut, illegal behavior, shouldn't come before us. But he wants to practice again. Put that on hold. So a new mother is a speech pathologist in a school. She has a baby. She's on maternity leave. The baby's 2 months old. The husband comes home and the speech pathologist is standing in the driveway holding the baby and they're sopping wet. So the wife breaks down and tells him what happened. I was overcome with depression. I tried to drown the baby and I stopped myself at the last minute. The husband doesn't say, come, let's go get you some help. He calls the police. And the police come and they arrest her and take her away. And she's determined that she has severe postpartum depression. Oh, I forgot to tell you this. On the Board of Ethics, there are only 7 audiologists and 7 speech pathologists. There are 2 lay people. And it just so happens that right now we have a judge and we have a neuropsychologist. And thank goodness we do. So this mother is found to have severe PTSD. So she goes inpatient to psychiatric care and she's out. And she's continuing to go to outpatient therapy. She has supervised visitation with her baby. Things are coming back together for her. But guess what? She needs to work. And she loves her profession and she wants to be a speech pathologist. It's a medical condition. Very treatable by medication. Put that on hold. There's a police detective in New York who has some strange proclivities. And he goes onto these dating sites online and he entices 5 women to be his online girlfriends. And part of his proclivities is that he has an affinity for young children. So he talks these 5 women into taking pornographic pictures with them and a small child and sending them to him on their phone. A speech pathologist entertains herself with a 2-year-old client, takes pictures and sends it to the police detective. One of the 5 women said, this is wrong. So they turn him in to the authorities. Whole thing opens up. Speech pathologist is arrested. Why would that come to us when it's very, very clearly an illegal matter? It's a matter of the law. Does that oversee us? Why does it need to come to us at that point? Isn't it open and shut? Don't need to waste our time hearing this case. Okay? Put that on hold. There's a speech pathologist in Florida who opens a shell company. You know what a shell company is? It's not a real company. It's just on the books. And she pays someone for a list of hundreds and hundreds of dead people's Medicare numbers. And guess what? They all needed speech evals and audiometric evaluations. And they bill for them, and she's doing quite well. To the tune of $18.5 million. Boom, it all falls apart. She gets investigated. She goes to prison. Why then do those come before the Board of Ethics? Because at some point, these folks may get out of prison and they may want to practice again. If it doesn't come before the board and there's no formal action, what's the recourse when they reapply or if they have someone pay their certification fees every year, and they do online CEUs in prison, what's to keep them from getting out and being a speech pathologist? Should the person with PTSD who tried to drown her baby but now has been treated and has medication be allowed to see patients? Should she be allowed to be a speech pathologist? Should the audiologist who bilked $12.5 million off the books, but was he doing audiometric services at that time? No. Did it affect his ability to be an audiologist, to provide competent clinical services? Now he's gone through counseling, he's paid restitution by going to this white-collar prison. Should he be allowed to be an audiologist? These are the ethical dilemmas and the ethical tricky spots that we have to decide, and that's why they come back to the Board of Ethics. Even if you think that's open and shut, they went to prison, no, they cannot. At some point, they may get out and they may come back and want to practice. So how do you handle that? And that's where, in Principle 4, it says you have to comply with local, state, and federal laws that govern us, or you cannot be in our profession. And that's where that comes from.
So then the mom couldn't have practiced?
That was up to us.
So, yes? Yeah.
So the question is, did we allow that mom to practice? Not yet. We suspended her for a little bit more time.
Okay.
So we're not saying that she can't come back. Actually, I think we revoked her for an X amount of time so that she has to come back, reapply.
So will she have to redo her CF year?
Yes. Yes.
Practice again. So then she would have to take courses that
So if you have to reapply for certification, you have to take classes to meet the new standard. So as of January 1, 2020, chemistry and physics classes will be required. And so anyone who is not CE'd by 2020 has to have physics and chemistry classes. So even if you decide not to be a speech pathologist and you want to be a stay-at-home mom or you want to go be a drug rep for a pharmaceutical company, maintain those C's so that if some point you change your mind, you don't have to come back in and take all these classes. All right, any other questions, comments?
Does the Board of Ethics ever start to lose their faith in humanity?
Does the Board of Ethics ever start to lose their faith in humanity? You know, when I first went on the Board of Ethics, I thought we were all Mary Inglebrights and that there's no way that we could do this stuff. And you read some of these things and you just think, oh my word, what in the world is going on? And then you get those cases where it's a parent who is not satisfied with the progress that their child is making, and so they file this complaint and there's no merit to it. You get those cases, or you get cases where it's an unintentional error. But what I have learned is that we all, at some point, may be in violation of the Code of Ethics, knowingly or unknowingly. So we all just need to be mindful. We need to be over diligent, we need to pay attention to detail, and we need to be hyper vigilant in our documentation. And we need to be careful how we date things, how we let those bills drop, because we all do that. We all get busy. We all do documentation the day after we see someone, maybe 2 days at sometimes, and we all have errors in our notes. If you've ever been writing a note and you've put the wrong patient's name in there, could that be an ethical violation? Absolutely it could. But thank goodness on the outpatient side, we have checks and crosswalks that say, hey, you saw this patient on this day, but you dated the note on this day. You need to fix it. So we have checks and balances. And on the inpatient side, you guys, at the hospital systems, at least they have them. In schools, I'm not so sure. So I get lots of questions about the ethics of a speech pathologist supervising a speech pathology assistant and speech pathologists supervising clinical fellows. So my last term, not this term, but the last term on the State Board of Examiners, one of the things that I did was I made it mandatory for ethics CEUs. And the other thing I did was I made it mandatory to have continuing education hours in order to supervise a speech pathology assistant and to supervise a clinical fellow in speech pathology. Because as we all know, the supervision of someone is a big responsibility. And if you're supervising an intern, that's different than supervising a speech pathology assistant than supervising a clinical fellow. And if we don't know how to do it appropriately, if we don't know how to do it effectively, it makes a big difference in our jobs and in the job and the profession of the person we're supervising. Because when we supervise an assistant, we're not getting that person ready to be an independent practitioner. We're teaching them how to be an assistant to what we do. And a lot of speech pathologists, when speech pathology assistants were licensed, felt like they were going to be putting their license at risk or their job at risk, and they didn't know how to supervise, but they were being told, you're going to supervise this person. So we made those requirements to protect the supervisor so that they could say, oh, I can't supervise because I haven't had the training to do so. We made those requirements to protect the supervisee, to give them a supervisor that now was comfortable, was in love with the idea of supervising, and had some tools to be a more effective supervisor. And we did it foremost to protect the people that those folks are seeing, that they're treating. To provide someone who's had competent supervision, because everyone has had a supervisor at some point who didn't do the job that we felt like they needed to do, who weren't instrumental in our learning and didn't teach us what was right and what was wrong, and didn't give us that good guideline for what we should do. So that's why we have those requirements for supervision. All right, thank you very much.
Thank